Hey Cam followers, we are back for day 2 out of 4 days with the lovely Dr. Cameron Black, who is giving up his time for free to come and talk to you about a regenerative approach to managing arthritis. Let me remind you why we do these lives. So, as veterinary surgeons, we have to be very careful about the advice that we give without seeing animals in our care. So the way that Cam does this to help people and still stick to the guidelines and stick to the regulations is that we keep our ears open, we find out what you guys are thinking about, struggling with, want second opinions about, and then we do these lives so that you can take the information away from them and tailor it to your case. So that means that we're providing for you. I'm afraid it's not on a silver platter completely devoted to you and your dog, but you can extrapolate and bring it into what's relevant to you. So this evening, we're going to have some slides again, and Cameron's going to talk through a case with us so we can get some more context to it. Before that, so Cameron, quick introduction to yourself for people that didn't catch us yesterday.
Sure. So I am a vet. I have a background in stem cell biology, works particularly in the space of musculoskeletal stem cells and focusing on the translation of science from the preclinical to the clinical. So I had a real passion that because we use animals in research, so we're reliant on the information that we get from them. And it makes such an impact to human care, but there seemed to be a bit of a gap for some of that knowledge getting into the veterinary space. So after leaving the research world, I worked and set up osteoarthritis and stem cell facility at Referral Centre, and we worked there delivering exactly that, just trying to improve our knowledge and understanding of how we can incorporate, and I'll say that word incorporate, not replace, regenerative therapies into the workflow, the sort of toolkit that we have within the orthopaedic veterinary space.
Yeah, so I didn't know very much about regenerative at all. So when the CAM website got written in 2016, I was a very big newbie to it, and I hadn't really heard many people using it at all. It's not commonplace in first opinion practice. So anybody that's listening and thinking, well, my vet doesn't do that, well, that is normal. It's still very, very normal. And I would say only a small percentage of practices are incorporating it into their work. Is that fair to say?
Yeah, I think why for people listening, why Hannah and I felt that we wanted to do this series of talks is that is absolutely fair to say, but it's on the cusp of becoming far more widespread. And so it used to be a real small handful of vets that were offering this, and it's steadily increasing. What makes it, what I would say is about to be the kind of real change to that is the number of commercial labs that are offering products. So it becomes much easier for vets to say, oh, I can do stem cells now. So we just with that in mind, we thought it'd be just really good timing, really cool just to explore what they are, how they work, what it means for the animal, what it means for the family, and just give people a better understanding. Because it's nice to know, but it's also kind of fun. It's interesting. It's new.
It's interesting, and I think from my perspective, so I've spent the last 4 or 5 years being pretty obsessed from the owner perspective. So CAM was originally created because I felt that owners really didn't have a good resource to kind of get an overview. And arthritis is a very, very complicated topic, and there's lots of different things that are happening at any one time that can have a really massive impact on your dog. And Cameron knows that I just am a massive promoter of don't forget the freebies. Oh my God, you know, the weight control, the lifestyle, the exercise, the rehab, massive impact. And that gets really quite neglected. And I'm going to be outrageous when I say this, I don't mind. A lot of stuff that you see online are connected to product sales. And we wanted to create a resource that didn't have a product attached to it. We wanted it to be not biased. We wanted it to be kind of like very evidence-based. Now, on the side of that, as Cameron has been saying, that regenerative is really coming up but it doesn't replace everything else. It's part of it. And one of the things that makes me a little bit worried is a lot of people will be seeing advertisements or hear on the grapevine in forums about this new approach, but they have no idea of how intensive it is. And I'm not saying it's intensive and painful. I'm saying that you've got to go through the right process. I think that's where we should start with your case study, so you can really illustrate. It's not just about going, I think the dog's got arthritis there. It's much more, you really need to know what you're doing, because otherwise it's waste. So, yeah,
I think just before we pop the slides up, people, and I think this might be part of the listenership as well, because of that's been going on, the approach in a lot of vets' minds to regenerative medicine either is, yeah, I'm going to embrace it, let's go for it, and maybe there's three parties. There's one that's all they'll do, and they're going to make their name in that area. Then there's the other ones who are what we're saying, using this kind of integrated, incorporated approach, and they see it as something that they can use if they feel it's right. And then probably the third camp is the charlatan, snake oil. It's not regulated properly. I'm not going anywhere near it. So for people who have approached their vets or are thinking about approaching their vets, I can understand if they come from that quite negative approach. And it's just, so what we're trying to do here is, as I say, is just put that information out there, make people feel a little more comfortable as to, well, if that vet that I trust now suddenly says no, why is it? And it might be that it doesn't feel that there's enough information out there yet. Or if one person, a vet, says, yeah, that's great, we can look at all these other options, and if it's stem cell seems right, then that's something that's on the plate. But then I guess where we start to move to the warning lights is if we're just getting the, yes, stem cells that will work for your eyes, your ears, your nose, your ankles. Let's just jab it everywhere. We don't need to look at anything else.
Yeah. And I think, as you say, it's got to be, people have got to understand the before, the during, the after, proper expectations, proper understanding of costs, etc. So when you're ready, I will share.
Yeah.
Okay, I am in control. Here you go.
You are in control.
I am in control. There you go.
Okay, are we good?
Yes.
So the plan for this, and we do have a couple other talks lined up, the plan for this is to set out the sort of pathway, and I'll use one type of, one case as an example of that. So we're not going to cover all the different options available to you. It's not intended to go through all the literature or anything like that, but it's hopefully that you'll leave the session today just thinking, okay, that's roughly what I can expect. Here's the things that I need to look out for, my considerations, and just make you feel that if you are going to go through this process, that it's not completely foreign to you. So I'm going to use as my little example. This is my friend and colleague's dog. Absolutely, its nickname is the Good Dog, but it fits a lot of pictures. It's let's go with a 8-year-old female neutered Labrador, and she has suspected bilateral elbow osteoarthritis. And 6 months ago, just started slowing down. Normally a very active, very playful dog. And went to the vet, and that started a non-steroidal, which helped. There was some improvement. Sadly, about 3 months later, things started to decline even further. So just some sort of notes for people that decline in mobility. It might be that they're not wanting to go for long walks, that after the normal walk they're just flat. They're not nearly as recovering as quickly. Subtle things that they might decide that they like sleeping. If they've got the option of 2 beds, they might decide that they want the downstairs one, or they're not bringing their toys out as much. So just these little things to kind of look out for. Of interest, we're going to say that a dog like this might be a little bit, not particularly this dog, but not uncommon to see them slightly overweight, and would not have tried sort of the core. I've put the cam tower there. I know it's on the website. we've got to be on message here. But
I was like, whoop, whoop.
yeah, and I know on the website it rightly states that that's not necessarily it weighted in importance or in direction. These are interchangeable, and they're all interlinked. It's very much that integrated approach.
I'm going to just put in the reason that we designed it like that is the volume of each section is what the owner can contribute to. So quite a lot of owners, when they arrive at the vets, they suddenly have their confidence and their competence taken away from them. They feel lost, like, oh my God, what's my role now? Do I have to rely on everything the vet? Am I going to be here every second Sunday? And we created this pyramid so that the volume, people could look at the volume of it and go, oh my God, my role's massive. What I do really, really matters. And one of the most important things is getting people to understand observation skills and being confident in how valuable they are. So at the bottom it is, you know, look at your dog, be aware. And it's very applicable to your case in that the intervention chosen, non-steroidals, we've started to see that it's not working anymore. It's not enough. And that would have been client observations and the client feeling competent and confident to say to the vet, I'm pretty sure that they're not sufficient now. So yeah, it's not a path. It's not like a runway. It's a volume of confidence pyramid. There you go.
Wonderful. The reason I so sticking on the owner identification part of it, for me, a strong part when we're looking at any kind of management of osteoarthritis is for families to feel that they can get some sort of feedback as to what's going on. If it is a sort of classic, we call it a primary or wear and tear style OA, it's been brewing for a long time, and the changes can be very subtle, and it also can be quite difficult if someone feels that they've maybe, oh gosh, did I put my dog through too much, or that was a lot of money, I'm not sure about the outcomes. But if you become a sort of a bit more fine-tuned and aware and observant, as you say, you'll notice subtle things like, oh yeah, actually he started sitting now where actually he used to just lie straight down, or he started getting his toys out more. That's usually a sort of common one, and then it just helps people stick with the process, because the treatment process is a long one. It's not like many other things where you can go in for 1 or 2 visits and a couple of weeks or even a couple of days later we're feeling much better. So I just think it helps both improve the outcomes of the treatment as well as improve in concert with improving client and family engagement. So yeah, that mention those things.
Good.
You're
in charge of the slide.
No, I wasn't sure if you had something to add in. Yeah, I'll go to the next. So if we look at this dog, we've had questions in the past. What does it mean when they said, oh, it's got a really bad elbow? So I've put those up, and we'll come to them. We'll come to the next. But so we traditionally, if we look at what we can do for dogs in this situation, and you can see some of them down on the left there. But at this point, I wanted to make it very clear that we should never go straight. Kind of purposely, the fact that I've jumped straight into it, I want to say that actually that's not what you should do. So we have many things that can sometimes, maybe not quite with this history, but with a lameness or an apparent lameness, or dogs not willing to exercise, there can be lots of other things that are causing that. Some of them can be quite minor, and others can be a bit more serious. You can have neurological issues that are masquerading as not using their legs normally. You could have, hopefully not, but you might have an infection in a joint. You might have sometimes it can be tumors that can cause presentations like this. We also have conditions of the immune system where the body itself actually attacks the cartilage layer, and that causes swelling in the joints, and it causes pain, and it causes them to slow down. And a condition like that, or most of those, can come later on in life. It's not necessarily that they would be seen at a particular age. So in terms of what we would do next, Hannah and I have been talking on this. You have to say you need a diagnosis, and that diagnosis must come through clinical examination, obviously a thorough history, a clinical examination, and then your other interventions, so your other investigations that you might want to do. So that may include X-rays, like we've got up here. It may or may not include a CT. That could lead to arthroscopy if we're happy that it's a joint thing. You might want to be taking samples from the joint, so joint taps, to rule out infection or rule out those immune conditions that we mentioned. And then with that picture, and it can include general health, for example, even a bladder infection can be linked to a septic joint. Wouldn't necessarily fit with the picture we're painting. The whole idea of this is just to explain that there's a lot more than just jumping straight at it.
Yeah, definitely. And I think everybody knows I'm quite happy to say I'm still on a really long learning journey. And I think the more I learn about this, the more I realise that everything is interconnected, so you've got to be looking at the back end and the front end in the back, so even if we're talking about elbows, we think that they're the worst thing in this dog. We've got really prominent forelimb lamenesses. However, you still got to look at the rest of the dog, and I think both me and Cameron have seen numerous cases where, the elbows are really bad because the back end is bad as well. The dog has nowhere to put its weight but through those elbows. And those elbows are going, but just give me a break. Just give me a break. You're putting more weight on me. So a lot of people who are interested in this, the vet in charge of the case has got to start from the nose and go all the way back and be looking at the joints, look at the bones, look at the soft tissue, look at the neurology. So a really, really involved clinical exam. And don't be surprised if they say, well, look, before we commit to this, I want to see what's going on in the back end because he's a bit stiff. He doesn't want to extend his hips. He's got muscle mass loss there. We need to see the bigger picture.
Yeah, completely. And that's a very common example. Muscle mass wasting at the back, but people are noticing that they've got big bulgy elbows that have sort of rocked out to the side. So it must be the front that's the problem. Yeah, so as I say, just to get through the idea that there's lots going on. And I think before I go into as I say, the sort of protocol that we'll be looking at, there's a really good argument if you're able, and we can talk about this when we go into the rehab bit, but if you have the patients the time and the dog has the time, that we could be doing a lot, let's say a 3-month program, and we don't even go near injecting anything into the elbows. And I think that that's not unreasonable. I understand that there's an awful lot of buy-in for that. But we have precedent for it in veterinary medicine, but also in the human field, that they will insist on weight loss, on strengthening, and they'll look at they'll look at any other sort of biomechanical issues you have, usually before they go ahead with something like a hip replacement. So that's something that I've grown in. I would say it's I probably didn't have that eye when I first started using Regen Med, but I increasingly trying to incorporate it. It's not always the easiest because of time, energy constraints, but it's definitely to consider. So if you do get that as an option, if I've been referred, but they want me to do 3 months on a particular drug with or without hydro and comfort and laser sessions, and start some joint supplements or something like that, then they're not fobbing you off. No,
they've got your best interest at heart at the end of the day, haven't they? And also, let's look at it from the science perspective. If you were to do a high-end approach to stem cells in a case of bilateral elbows and you didn't get the results you wanted, and it was actually because there was tendinopathies up in the shoulder or there was something else going on, and you thinking, oh, my science looks really bad, but it's nothing to do with your science. So I think just be prepared that you're going to have to accept thorough examination and maybe the long-term approach.
Grant, and just before we move on, because I have had this question, can you see the cursor on the screen? Does that come through? Yeah. So just to what people might say, if I took an X-ray and said, "Oh, it's got terrible elbows," and you're thinking, okay, but I don't. Surprisingly enough, I don't see many X-rays of dogs' elbows in my day-to-day. Simple things to look out for. The bones have two components to them. They've got a kind of stronger outside part, and then they have a more spongy inner. And generally, what we're looking for is smoothness. So they're covered in a very thin, tough layer, and the bones should be smooth. All the surfaces should be smooth, and you should be looking for continuity of color. So if we see at the back here, suddenly we start to get roughness, and we've got this whole contraction of it doesn't look like it belongs to the rest of the bone. You know, that would normally be continuing down and around. So this is an example here. It's an extreme example of how the inflammation has just continued and continued. You've ended up getting the bone has become so reactive that it's formed a new bone outside the joint. Some other sort of more subtle changes here on the radial head. So it's one of the two bones of the forearm. And you can see these little, almost like a little seahorse or something riding on top there. And another sort of mild example. I mean, there's lots of things in here, but generally the rule is that we look for smoothness. And even in here, there's a structure that we can't normally visualize, but that's a bit not for today. We're looking at the bottom one. So this bit of fluff here is coming off the bottom part of the upper bone in the forelimb, and that's again another sign. And then you've got these small little hooks. And you've got this area at the back. So what happens is that as the process continues, the inflammation it's bubbling away. It's not raging. It's not an acute thing, but it's just always there, and it starts to cause a lot of reaction. For those who were listening yesterday, we saw all those different small molecules that have different functions. Sometimes they're good and sometimes they're bad. And this is a case where if there's a sort of balance, the seesaw's tipped, and we're now we've got too much going on. And one of the side effects you see there is this what we call new bone formation. So this is why you'll get your dog, you've probably, I'm sure this has been covered, but your elbows of the dog might pop out a little bit or look thickened, and it's also why they'll be stiff, because as you just imagine, mechanically, that joint has things in the way. So yeah, just wanted to cover that because, as I say, it's been asked.
Can I just butt in, because this is just a little peeve of mine. Even if they haven't got loads of bony Lord of the Rings, doesn't mean that they might not be painful.
Completely, yeah.
I think something that we're really learning is pain is what the dog tells us it is. And you could have x-rays that don't look too bad, but the dogs know that really, really, really hurts. So the whole presentation of arthritis is very wide. And you can have dogs that have very little osseous change, but they have got acutely painful joints. And then you can have a spaniel that's got joints that don't even move anymore. They're probably ankylosed with so much new bone. And they're like, yeah, I'm fine. So it's quite crazy, the different extremes that we can get. Just needed to drop that in there.
Yeah, no, and this was chosen to help sort of demonstrate some of the changes, but I wholeheartedly agree with you. And there's a couple of papers that show that there's a very, very poor correlation unless it's in extreme cases, between some of the things you might see on X-ray and actually and the damage you would see if you looked at the cartilage surface. So. Yeah. There really isn't much substitute for getting a real eye on the surface if we think that we're then going to go and do something more invasive. But that's just another discussion. But you're absolutely right, and good point to bring up. So if we move on to kind of the intention, let's say we've gone through the journey. We may or may not have had some weight loss. We may or may not have tried different non-steroidals, whatever it is that's been agreed, as long as we're looking at it as an integrated approach. And we're now at the decision, okay, I'm going to go ahead with stem cell. So what does it mean for you and for your dog. So we're going to talk about adipose-derived stem cells. Again, and this is a repeat from yesterday, you can get products that use a combination of blood and bone marrow derived, but predominantly the service that you're going to be offered is going to be someone taking a fat sample, and we take that from either under the skin, or it can be from within the abdomen through a very small incision. There's sort of two approaches for it. And why we're interested in the adipose, again, a quick repeat, it's actually the fat. We're not interested in the fat component itself, but the fat's full of very small blood vessels, and it's sort of supporting network. They have different types of stem cell or stem cell-like, certainly therapeutic cells, we can say. So we take the fat sample, and that is done under general anaesthetic. So that's your first consideration, is that you obviously need to anaesthetize your dog. So that's where we had a really good question yesterday about whether is there an upper age limit? And I don't have an answer in science as to when it stopped working. I don't think there is one, but my far more consideration should be on whether or not we want to do it in that dog and how it will cope. So I am talking about culture expanded cells. So that means it is a two-step process where you have the surgery, then that sample is sent off to a lab, and we're talking about fat here. So again, I know it's a repeat for those yesterday, but we usually use enzymes to break this down, and then you end up with a different separation. So you have a sort of the fatty layer that you don't want, and the SVF here, that's the stromal vascular fraction. So you can remember that we are breaking apart all this sort of network that holds the cells in within normal tissue, and then we've got the free cells, but because we've got whole fat, it's everything that was in the fat with the actual lipid bit removed. So that includes blood vessels that have been broken apart and the stem cell, if you like. So the next step, and again, I'm talking about culture expanded. So there are some products that at this stage would re-inject. So the evidence shows that that's really not nearly as effective as what we're talking about, the culture expansion. Now, the stem cells that we get, the MSC, mesenchymal stem cell, I also like the term the medical signaling cell, because that's kind of what they do.
Mm-hmm.
They have this really nice property that they stick to a particular type of plastic really well, much better than most other types of cells. So it's a really easy way. We whack down on this culture plastic, and then they're grown in a lab until you get the right number that you want. So the time from going through the surgery to coming back in for the injection, it can be slightly altered depending on the growth, but let's call it 10 to 14 days. Mm-hmm. So at that point, then your dog's coming back, and then it has to go through another heavy sedation, but usually switch to general anaesthetic. And at that point, we're injecting our product. So just for interest, if I go back, if you spin this down, that the white part at the bottom is that's the cells, and all this is the media that they've been growing in. And so you've got lots of options. I should have showed you this sort of yesterday. And I mentioned this because you may well get offered them. Where is it? Are we talking about autologous, which is what we're describing here, from your dog back into your dog? Is it adipose or bone marrow? We're talking about adipose. We're not at this point adding in anything else, but we could. So there's lots of questions about PRP and other things. Is one better than the other combined? Absolutely going to talk through all that. And then whether we inject it with a gel. This picture actually, just for highlighting, this is stem cell preparation going into the elbow. This is me combining the different products together. So I sort of pass it back and forward until they're homogeneous, and then injecting those. So there are a couple of options there. So at this stage, we've gone through all the proper diagnosis. We've had a chat about all our different options in terms of lifestyle changes, other interventions that may be less invasive. But we're going ahead with this because we think this patient's a good candidate. So they've had the surgery, 10 to 14 days, come back and dog gets injection 1. So I absolutely, we also had a question yesterday, which we didn't get a chance to answer live.
Shall I read it? Do you want me to read it?
Yeah, go for it. Yeah, good time to do it.
It's Claire Blackledge from yesterday. Thanks, really interesting talk. My 8-year-old lab had his adipose stem cells injected almost a year ago. He has improved a little, but not as much as we had hoped. The laboratory still has his stem cells. Is it worth getting a second lot injected? And is there an optimum gap between the first and second dose? Thank you.
Yeah, so that's a really important question, and I'm thankful for it. So what we went straight away when I started this work in the clinic with a repeat injection, and because we had enough data, well, there was enough data on the impact of a single injection. So the answer is that I would always recommend. I mean, there's even a double injection. And there's even people who are doing triples. I mean, we're now at the stage where people are just trying to optimize the protocol. We think there is efficacy, but how can we make this work as best to its maximum capacity? So in answer to that, I would have done a second, and quite often what we do is 2 injections, spaced anywhere between 6 to 12 weeks. I think that covers what a lot of people are doing out there. And then the option is to re-inject at 6 to 12 month intervals if it's appropriate. So if we look at how cells are stored and how they perform when they wake up, I would be using, there's a lot of different things, but up to a year I would feel is fine. And the labs will know what they're doing. There are ways that you can encourage the cells that have been sitting in usually liquid nitrogen to come back to life a little bit. So I would feel okay with that, and indeed have injected dogs with cells stored up to 2 years, and I still saw an additive bonus or benefit to that injection. There is, that may be a bit contentious. I appreciate that, because there's a bit of a differing opinion. But in general, I would say yes, because your alternative is that you've got to go through another surgery. It might well be that, hey, there's a benefit of, you could consider having the joint injected, but under the same GA, taking a fresh sample. That's also something that I often would do. No,
that's good. That's well answered.
Grand. Yeah, so I was going to talk about what we would expect is, as I say, those 2 injections. Some of the things I wanted to point out is, or one of the main ones really, is that it can often be quite painful. And you often, it's not uncommon to be dealing with families that are, I will tell them it can hurt. The dogs can be quite uncomfortable for 5, 6, 7 days afterwards. Even knowing that, I think when they see their poor dog and they really are just quite down in the dumps, it can give people a bit of a shock. Now, it doesn't happen with every dog, but I would say that there's, particularly in a joint that's really quite painful. You can imagine I'm putting a needle. Often you have to navigate through some of that gnarly bone that we talked about. And in dogs that don't have that gnarly bone, that have the really sore inflamed cartilage, the needle may well be making contact with that. The other point is that the joint gets expanded in the process, and the synovial membrane, the sort of capsule around the joint, is really, really sensitive, and so it's not. It has those considerations. So when we talked about, again, going back to what the age, the considerations are done under general anaesthetic, and for all dogs that carries a small risk, and it's done under, obviously we're doing this repeatedly, coupled with the fact we're putting a needle into the joint, which is sore.
Well, it was really sore.
Yeah.
And I must admit, I did the whole owner, oh my God, what have I done?
Yeah.
She did bounce back after about 48 hours, and the tail came up and the dog was happy again.
Yeah.
So.
No, and it makes it so much, it's worthwhile when you if you see them enough and you know, like, just come talk to me in 2-3 weeks time, and not all the time, but invariably it's been the right decision. But there is that process that you go through where you're thinking, oh gosh, that's a bit harsh, isn't it? So we obviously make sure that they're covered for pain relief, but it's not without its difficulties in that regard.
Mm-hmm.
So I wanted to talk. That's that. So we've done the surgery. We've had about 2 weeks, and then we've done the first injection, and then it's about 6 to 12 weeks for the second injection. And thereafter, this is where monitoring comes in. I'm going to talk about that in a couple of slides. But thereafter, it's finding a time, a balance between should we repeat or should we just keep going with supporting with some of the other modalities that we're going to talk about next. And I don't have that becomes more of an art than an algorithm. So the positive thing, why one of the benefits to stem cell therapy though, is that you maybe have injections for 5-6 repeats. So you can conceivably get 2 years of treatment from the initial surgery. That varies between providers though, but that is certainly something to consider.
To the dog as well, isn't it? And I think that can be really hard for vets to give the specifics. So I was listening to a podcast a couple of days ago, and it was talking about shockwave, and someone posed the question, well, if the dog's done really well after the first one, do I need the second and the third? And the person doing the talk said, well, we can't actually say that, but we know that this protocol works. So this is, we do 3 because we tend to see a marginal improvement again and again, and then we sit pretty for a while. And I think that's just really fascinating because there's so much that we're still learning. And for me, you know, when an owner's coming into this situation going, oh, this is a bit, you know, you're still learning as well. Communication's got to be awesome. You know, you've got to have a really good rapport with your vet. You've got to be part of the journey. You've got to be doing the, you know, objective monitoring, giving the feedback, and you definitely have to take the advice regarding post-operative rehab and recovery. But there is there's a lot of communication, isn't there, Cameron, between you and the clients?
Yeah. So we'll just the 2 slides time we'll sort of look at how I would certainly hope that what the things you may be offered in terms of follow-up. But yeah, there's a lot of communication. Invariably, OA cases are need management. It is a management. It's not a treatment. So I think it's important, particularly if people have put their trust in you to go through with that process, that you stay in contact with them, that you are there for that point of care. But it's important because it helps people just feel confident in the journey, be compliant with the journey. It helps me generate data and understand what's going on. So yeah, we stay in touch both ways. Is a must. It should be a given, really. Yeah. So if we go to this one, I just quickly wanted. I mean, I don't think we maybe want to leave some time for Q&A, but these are some of the modalities that can be offered. And usually, you've mentioned the shockwave. Often you'll get lasers, so the sort of top left. Some of the other ones is we talked at the beginning, if we have some muscle tension that actually may be secondary, that may also be more uncomfortable than the arthritic elbow. Should we look at incorporating, and some practices do, incorporating acupuncture alongside more traditional hydrotherapy, either underwater treadmill or swimming. So the joint, I think the important part is, and you guys have probably heard it more than I have if you're following Cam, but the important part to remember is that the pain from the elbow, let's say, is only part of the process. it may be the most pain generating unit, but there's going to be other parts that you could look at treating as well. So the guy up on the right having a good time is getting his pens, and that looks at something called gateway theory of pain, where we can perhaps reduce the sensation of pain, because all too often they've got so used to feeling uncomfortable that the brain is just sitting there like a sort of, nervous, waiting for that next impulse that's saying ouch. So you have to look at the whole system to say, well, what's my intention? Well, my intention is to make my dog feel more comfortable, and stem cells, I believe, has a role to play in that, but never in isolation. So I don't know if you did that slide wanted to add anything.
No, I think it's really true. And from my perspective, and for CAM followers, is that sometimes I get a little bit worried about doing the high-end talk. This is like a high-end talk, because there are going to be people following this that have that wave of, well, I can't afford it, and this is for me. And now I feel bad as an owner because I love my dog, and my dog is everything to me, and I am not giving them what they need. Don't feel like that.
Not at all, yeah.
Anything this slide shows you, there's so much more that you can do. And as far as I know, there is no pinnacle healthcare plan. There isn't this protocol is gold standard, is always, the thing that we aspire to. Not at all. And I've seen dogs that have lost weight and they've put some rugs down and they've stopped throwing the ball, and the dog is like, well, you could have given me stem cells because I feel good. And, do remember that there is a wide range of interventions. So don't feel guilty listening to this if it's never going to be an option. Just learn, pick up little bits and bobs. I'm sure we'll do 10 top tips where Cameron will step outside of the stem cells, and we'll talk about all the other things. This is an inspiring slide.
I think I really appreciate you adding that in, because particularly if someone comes to you and they're interested in stem cells, then there's usually they can also, or they've had it mentioned to them, there is that sometimes a guilt. Well, I really don't know if I can afford it. And you're thinking, can I just backtrack? 5 years ago, we wouldn't even be having this conversation. We've got to the point where we have this technology, and not just stem cells, hip replacements, elbow, arthritic, all these sort of slightly more complex surgeries that we wouldn't normally have been doing. And why I like chipping in with Cam is because so many of the conversations that you'll have with clients, and it might sound like you're not being taken seriously when a vet turns around and says, well, they could really benefit from losing some weight, or do they use stairs at home? Is it possible that you could maybe reduce the amount that they, or can they use a ramp? All these sorts of things, and they work as well. So I wholeheartedly echo that sentiment. But it's just to let you know what else you could be looking at, I think. So I wanted to go and just look at what sort of things that we could be checking in on. What sort of data can we collect? How do you know if it's getting any better? How do I know? Look, there's no perfect tool, but just an example of these 3 overlap. The top one, you don't want to read these, they're not that interesting, but these are little sort of exercises that we can do in terms of monitoring exercises to grade the severity of a disease in the top one. The second one is to grade the pain, the impact that pain's having. And then that third one, the load, tend to use quite frequently, because that's about how families can give their assessment of what's going on. So no one knows your dog better than you do. No one sees it more than you do. But sometimes it can just help to actually, how do I articulate that? Oh, that's a good point. How are they rising? How are they exercising for longer, or are they pulling up? Just things you makes you ask. But the nice thing is you can do this repeatedly, and you end up with a bit of information from it. They're not flawless, but it helps. And I think
it helps to conversation. I think it gives structure, which is important. Right, I don't think that they're flawless. I've had a couple of cases recently where I've used these and they really haven't picked up how bad the dog is because they're quite 2D and the dogs are more of a soft tissue pain, and they were like manic, so they did still run and they did still do everything, and it just didn't the charts didn't reflect the actual physical, what I was palpating, what I was seeing, all the subtleties. But they really do have a role at trying to keep a uniform approach, a crib sheet for the conversation, a structure to the repeated consults, so you guys feel that everything is being covered. And we've got the OA booklet, which if any of you've got, it's about having structure, and it's about each consult being repeatable so that you feel all topics are covered. You've got value for money. You don't feel that you're going home with questions, and these do help.
The other thing that we've got, and these are just two examples of gait analysis. Again, not a perfect system, a tool, shall we say, but can be really quite handy. So I have these are just two examples. The top one is probably more commonly used, and the bottom one is sort of newer to the market. It's from the human field making the transition. But if we just look at this little area, so what it does is it gives us a sort of score. We've got what are the numbers like compared in our feet, and we've got a massive difference, a discrepancy. Is one leg really just not carrying the weight like the other legs are, or do we have a shift from the front to the back to the front? As we talked about in the beginning, my elbows might be really painful, but that's because I can't really put any weight in my back and it's all going through my shoulders. So nice little tools to have. Again, can be used just longitudinally, so we can generate data over time. And they're all variations. There are a lot of different options out there, but in effect, they kind of work where you've got these pressure sensitive tiles. They come in different forms. There's also the force plate, which is slightly different, but you get similar style information. Basically, it's a way of putting a number to how your dog's walking, how much force or weight that they're putting through their legs.
And again, it's not common for practices to have this. I've only one practice that had this, and this it took a whole room. There was a whole extra room for this. You have to take this all into account. A lot of vets just don't have the capacity, and they're expensive. I can't remember what the force plate analysis was, but I think it was 100 and something thousand pounds. It's not a cheap piece of kit, so it's got to be justified use. So it'd be nice when everybody has one.
Yeah, well, no, and the prices are variable. They're in the tens of thousands at least. Why I like to share this is because I get questions about is the papers out there, the results, and often gait analysis will be in these papers, and so that's why I just think it's helpful to know that that's out there. Going back, this is very applicable. A chat with your vet, just measuring the same criteria, and there are other tools out there. I think there should be some form of follow-up that gets some form of continued engagement, because it's better for me as a vet. It's better for the dog as well. I think that's my feeling on it anyway. And to give you everyone an idea. So let's say we've gone through the process as described, the surgery, the 2 injections, the follow-ups, and I'll go to this one first. So this was data that I was heavily involved in, but I have to credit Fitzpatrick Referrals just for honesty's sake. What we look at here is that we had that gait, the walking thing, and so we're looking at this is asymmetry. So we had dogs that had one leg that was painful and the other one wasn't too bad. So it was quite a nice control within the dog. And this is following a protocol of repeat injections. And so we usually, interestingly, this is not an uncommon thing. We saw an improvement for 2 weeks, and then there's it's not working so well, and then there's a gradual if you're drawing a best fit, it sort of comes more, it's not as jerky as this just with the time points. So what can I expect? Well, not every dog will get a benefit from it. Hands up, that's just not possible to say. Most dogs will get some benefit and some dogs will do really well. Timeline, let's say about the 4-week mark for most dogs starting to feel a bit better. And that can last quite well, and other dogs start to even get worse again from this point, which is why we started to introduce the second injection. And this is a questionnaire for how do you think your dog's doing, and this is a single injection out to 8 weeks. So you see that little like, yeah, it's doing. So look, the score is getting lower, so it's doing better and better. Say again?
So the dog's improving, both
yeah.
Right, showing that there was improvement. And was it 6 months is the final score on the lower axis?
Yes. So with 2 injections we had, so this is where we were, we had lots more weight going through one leg than the other, so we're quite wonky, it's asymmetric. And then 6 months later, we're showing that we're much more similar. We're not perfect, but we're much more similar between those joints. And so, and again, it doesn't work for every dog. And I think the person providing the injections knows you get a feeling for which dogs do better. These are predominantly end-stage osteoarthritis, well, they are end-stage osteoarthritis. So there's probably didn't have further options available to them from a sort of invasive or minimally invasive point of view. And going back to your point, there's plenty on offer to them in management, absolutely. Yeah, so just, and then going, so that's that roughly. I wanted just to talk a practicality.
Here we go.
Yeah, so I've covered, is it a once-off? I would say most people aren't doing it as a once-off. But adding to the point about there are lots of options. I had a friend who's an orthopedic surgeon, and he says it was a really good point. But if you have lots of options, it probably means that no one is the best choice.
Yes.
So I just think that's quite a nice mantra to have in a way. So you will get people doing it differently, but this is how I did it. And then, but if we look at the cost side of it, this is the point. It's not cheap.
No.
So at this stage, it's why things like all the management options that we discuss, things like looking at different pain relief, maybe it's more beneficial to try hydrotherapy with some pain relief, or just simply go for weight loss and some nutraceuticals and see how you go for 3 months. I don't think there's anything wrong with that, because the price on that might be hundreds of pounds, and we're talking, depending on, but we're talking at least 2,000, probably 3,500, 4,000 for surgery and repeat injections. Because, again, I've come across quite a lot of discrepancy in charges there. And so it's really important, because you have.
Yeah, and I think a lot of people are going in and multiple locations are being found, and then people are feeling that, well, if I'm there for this, I might as well get that done as well. And suddenly bills of £5,000 to £7,000 is not unheard of.
And then you do have that sort of in for a penny, in for a pound scenario. Well, this is my treatment course that I'm now going with. Ooh, I don't have any insurance left, if you did have insurance on it. So that for me is one of the most ethically important aspects, is that if you have a pot of money to treat a condition, either through your insurer or for your own savings, the vet has an obligation to make sure that they're using that in the best way possible for the animal. And often there would be situations where the dog may well have been there are situations where it's suitable, but you get comorbidities and they may well need it for something else. And so it does. There's a lot. It starts to get nuanced in that regard. But if we talk positively about it, you can have some really good results. And from the first surgery, you've got a lot of cells in storage, so you can pay that upfront cost. Your subsequent injection costs are a lot less. So it depends, but we could anywhere from 500 to 800 for getting an animal back in, putting it under, injecting. And that, yes, as you say, it depends on how many sites, but I tend not to add too much per extra site, because it really is more of a consumables thing by that stage. The cell culture has been done. But that's just my view on it. So you can end up with a couple of years of a dog that's doing much better. If we look at some of the surgeries, I don't want to get into an area that is not my place of expertise, but you can also have bilateral elbow, some sort of procedures at £2,000 each, and the dog does well for about 2 to 3 years. So this is, again, making it a bit harder for people in terms of, okay, well, what should I do?
Can you imagine? Okay, so I was thinking about this the other day because I am sad and I need to get life. This is so difficult. Like, if now and Luna with arthritis, knowing what I know, oh my God, decision paralysis.
Yeah.
There are so many different options, and there's such an emotive component to it. And I feel quite strongly Holly's Army and the whole CAM support system with the CAM ambassadors and the CAM team, because they're all going through it or have been through it, they're brilliant for this. But owners need so much more counsel, because these are big decisions and nothing comes with a promise, and you've still got to manage the dog after. There's apart from the young dogs that have got dysplastic hips and they have a bilateral hip replacement at the age of like 2 or 3 years old, okay, different kind of story. But the majority of these dogs really do need management for life, and it's hard work.
Yeah, I think it's why we go back to well, who should I go to? And if you're going to someone that is experienced using regenerative medicine as part of their regular treatment options, they'll be able to guide you through this. They'll say, actually, you know what? We find that if we scope a dog at this age and we get rid of that fragment, that's going to give you better pain relief at this stage, and we can look at other options as time goes on. The idea with Regen Med is that there's no reason that you can't be combining it with other things, and people should be, in my mind, seriously modifying their prices if it's going to be done at the time of another procedure. But it's quite flexible in that regard. I think if we looked at today's case, it's quite a nice one. It's quite if everything's pointing that it is bilateral osteoarthritis, nothing else that we want to be doing. We don't want to put my 8-year-old lab through a partial or total joint replacement, and the joint surface is probably very worn, not going to be much benefit to scoping it. We would want to, or we simply just don't want to put them through that level of intervention. We would like to do something that can go in the joint and that has a good chance of making them feel a bit better. Stem cell comes into play. That's a much clearer picture. It's not the only option, but it's becoming increasingly clear that it's a very viable option in that regard.
Yeah, and I sometimes, whether right or wrong, have been it's such a tricky topic for vets to talk about money. But the truth is, sometimes you do have to say to people, right, well, where are we budget-wise? And then I can choose a treatment plan to fit. It isn't that it's going to be less valuable. It's not less valuable, it's more suitable. And that's got to be made clear. And I think it's almost like a big elephant in the room that vets have now got to the point that they're a bit scared about talking about money. They're going to get it wrong no matter what they say, for bad press. But we do have to ask the question, because I wouldn't want to be talking to someone about stem cells if it was never within their price plan, and now they're going to go home and feel guilty that they can't give it to their beloved dog. So I don't think it's bad to say, look, let's be frank. Where are we in financial capabilities? And I can get you an excellent plan to suit that. but I am known for being Captain Blunt, so.
No, it's completely, it's just so important, and there are some vets that are really good at it. I'm not bashing anyone. I think as a profession, you struggle to know what the right thing to do is, but almost always you hope your heart's in the right place. But it's a difficult thing to cover. I just wanted to add one thing on insurance. I've seen on some websites of people offering stem cell work that the comment is that most insurers do cover. I would say that my experience is that's not the case. At best, it's half of insurers, certainly in terms of underwriters. How that equates to actual numbers of pets insured, I don't know. But there seem to be, rather than increasing in number, decreasing in number. And that's one, because I think if everyone knew that it was covered on insurance, they'll have to be paying out a lot more for this. They would rather insure their dogs.
I'm not going to mention names because I haven't done any research recently about who does and doesn't. Holly was with her, but Luna, I've taken around with a company, and I know now they've changed their mind and they're not coming now. And I'm like,
Yeah. And I would add that it's even if you've got lifetime, high-end lifetime cover, it's not to do with the type of policy, rather than whether they're choosing to include it. So please, if you're going to think about going that route, do check, because it's not. The advantage though is that you should have all the investigations covered. So the first part, and if you do go for X-rays or further imaging, those things are going to be covered. But if you go through specifically stem cell, it's going to be an exclusion. And so just please make sure that you check that.
Yeah, okay. So we're at an hour. We said that this was going to be a short one.
I know, so I'm rambling. That's me anyway. You'll be pleased to know.
Let's just answer a couple of questions. A good one from Lynn. Good one, Lynn, liking it. In which circumstances would stem cell treatment not be appropriate, aside from affordability and the risk of GA? Put the other way, which dogs are ideal candidates? Yeah.
Do you want to take me off the slide?
Yeah. Oh yeah, we need to see your face again. There you go.
Yeah, I know what I'm talking to.
Yeah, so are there dogs that you would just go, no, I'm going to cope that stem cell is not the route you want to go down?
Excuse me. Is the implication that we're talking about severity of disease, or just in general, which ones are suitable, which ones aren't?
I think it's more about severity of disease, maybe comorbidity, but definitely taking out the equation of the GA risk and the affordability.
Look, well, as part of everything, there will be a general health screen that should be provided, and you'll know whether or not there's something that we should worry about that's contraindicated. I would say that with an experienced team, simply being an elderly dog isn't a reason not to GA, with the understanding that you should be fairly confident that other modalities wouldn't be more appropriate. So if you do have an older dog that's never really tried having 2 pain medications and has never lost any weight, then why are you jumping straight to general anaesthetic for stem cells? That's just madness. The going the other way, because I think it's important. This is one of the reasons that the Regen Med, I don't know, movement, I'm going to call it, cops a lot of flack, shall we say, is that this idea that we can't do other things. So particularly in younger dogs, when the pathology is just starting out, if we have these malformations or these sort of developmental elbow disease and that sort of a thing, where there's a biomechanical mechanical aspect that could be corrected. A lot of the pain in younger dogs comes believed that it's actually in the process of these fragments and things forming, rather than, so it's the earlier part that's really painful, and that's when you can surgically do a bit more for the dog. In some dogs that are middle-aged, and even if they've had prior surgery, there could be so in terms of elbows, there's a range of surgeries in increasing severity that are options. And to be very honest with you, you might only know if they're appropriate if you're scoping them. So it's not clear cut on that. I would say that the easier one for me is, as we've described today, and it does the severity of just how old the dog is and whether or not I think it's going to be able to manage the repeat process more of putting needles in joint and the recovery from it. So if you've got multiple joints impacted, do you want to be injecting bilateral elbows, bilateral stifles, bilateral hips, and maybe an LS steroid, which I've seen happen many times, and it doesn't always go so well. So I think if the age of the dog is less important than, say, comorbidity and in terms of how I feel that they would come out of the other side.
Yeah. Okay. Got this. This is one that I cannot answer because I have no experience with shoulder replacements at all. But I do know that we did a talk with Karen Perry Butler. So if you were to go into their Facebook videos, which is on this page, and you dig out via the search option, Karen Perry Butler and shoulder, we did about a half an hour talk about surgical interventions of the shoulder. And I can't remember whether she said we're still a long way off with shoulder replacements and they're still very much at the arthritis range. I can't remember, but if you go and have a look, and I'll go and have a look too and get back to you. Do you know anything about that?
Yeah, I think there are, I mean, it's early days. I've had exposure to them. I wouldn't necessarily say that there's by no means are they available broadly, even in referral centres. So it's different. You can, for lesions like OCD, so a kind of very clear focal developmental lesion, there's quite a lot of things available for that, and there's some quite nifty. We'll talk about them in 2 days, but there's some really quite fun biomaterial things where you are growing new bone and cartilage into that defect. But in terms of shoulder replacement, again, I'm not an orthopedic specialist, but I would say that I would be comfortable saying that there's certainly not something that is going to be widely available. No,
but do go and dig out the Karen Perry Butler one, and we do believe she's coming back soon to talk about kneecaps. So keep an eye out because she will definitely be the person to ask. Really good question here from Laura. Can you inject arthritic feet?
She couldn't be more accurate in her description. Fiddly and small. You can. I've never had I haven't purposely. I've done PRP in those small joints. I've not done stem cells. Because the discussion with the ortho teams is that even depot and PRP, etc., it's not particularly satisfying, and it can be quite sore. I mean, saying that, I've seen some dogs that have done pretty well with PRP, and you can get a needle in there for most breeds. You can do that. And I think, particularly thinking of those, you get spaniels that just have these.
Oh, they're just jazz hands.
Yeah,
just
jazz hands.
And I just think
those start to inwardly rotate, etc. Yeah.
Wouldn't it be frustrating if, like, 3 out of 5 did actually quite well, but 2 let the team down, and then the overall picture was negative? It's quite difficult. That's a really hard area to go. Is it working or not?
Yeah, no, and completely. And you don't see. The things when they present, they are usually at that stage, and I'm not sure that anything, perhaps it's an arthrodesis if it's causing them that much pain. In that itself is quite difficult. And
yeah, Karen was saying that you can actually just cut the joint out.
Yeah.
And but what surprises me about digits is there is so little circulating about them. If you go into any of the textbooks, you don't see many articles about digital OA, and it's so prevalent. And you're thinking, they're walking on these toes. And I did have a little glimmer of hope. I can't remember who it was. It might have been Duncan Lascelles recently was saying digital OA doesn't get their attention that it deserves. You know, but in the vet textbooks, we very much are elbows and stifles, and you know, so.
Yeah, no, it's a good question. It's something that I just don't get enough cases to generate the data from. So frustratingly can't say much. But you can inject them. You can get something in there.
Another question: is it more effective in some joints than others?
I would say yes. I think this is purely anecdotal. So and a lot of the papers that are studied they just lump all the joints together and say we injected 67 joints, and that'll include elbow, stifles, hips, and that they've looked at quality of life and they've got better. There's not a lot that look at doing focusing on individual joints, that they may well subdivide it within that paper. My experience is that any of those, I'd say elbows and hips tend to do, I've been surprised, tend to do the best. Stifles, I think, is a bit more going on in that joint. And if there's cruciate and meniscal damage, that's quite painful. And I'm not sure, I mean, still would, if I knew that I had a sore stifle and a sore hip, I would definitely be injecting both, because if you don't see or treating both, because if you don't see improvement, you're wondering, well, should I have done something with it?
Should I have done the other one? Okay, question here. My 9-month-old lab pup is scheduled for a stem cell injection next week. She's TD, had a successful arthroscopy 2nd of December. 30th December, she had PRP, harvested stem cells. She is hydro massage each week, along with other interventions, and is no longer on NSAIDs or on any other meds. She has not been lame since the night of the PRP injection. She does not appear in pain. Should I delay the stem cells, as other treatments to date appear to be working? Wow, that's one of those big questions of there isn't definitely an answer, but it's more of an opinion, isn't it?
Yeah, and if we look at the rationale of why we do repeat injections, is that, as I mentioned yesterday, but cells, they're affecting an anti-inflammatory, but also a pro-building effect, and they do perform better. Certainly in a lab, they act better when they're in a healthier environment. So my feeling was that almost the first, if we're looking at going back to the elbow thing or any other joint, the first injection goes in and does the job of calming things down as best it can, and the second injection over the top of it is allowed. There's some of the sort of TGFs, the more pro-growth factors can have a bit of an impact. So
healing cascade again, doesn't it? You know, you got your inflammatory zone, and then you get in there with the remodeling and give them an extra kind of boost then. But so
remind me what the timing between how long it's been since the PRP injection?
So the PRP injection was done on the 30th of December. And so we're now, what, the 2nd of Feb or something like that? So,
I think that there's provided the injection itself didn't seem to be causing too much pain. I think that process appears to be logical. But as you say, I don't have an answer. I don't have a clear yes or no, but it's certainly not illogical. I would maybe personally think about stretching out a little bit longer, but the cells, to put in, why you would inject the cells now is that they're going to be able, if they were able to help with the OCD, I mean, that in itself is a question, but if they were able to help with the OCD, they're going to have a better chance of doing it going in the back of a now calmer joint.
Yeah, and that's what we were talking about before, is that all of these other things done, the weight loss, so bringing the inflammatory state of the body down, you know, getting a good course of anti-inflammatories in there, and get that sofa ready for that stem cell to sit in, you know, make it nice and comfy. We're going to stop there today, guys, because this was supposed to be the short one.
Oh, no. Well, if I can discourage anyone tomorrow, we're going to be looking at what's out in the literature. So,
Woohoo!
but more than that, I guess it's another opportunity. With that, we can look at things like what gels should we include? What about PRP? So we'll cover that a little bit as well, and then maybe we'll give a few more opportunities for questions.
Well, guys, carry on putting your questions in, because what we'll do is we will cover them tomorrow. So if you're watching on kind of catch up, you're like, oh, well, I need to ask a question, do put it in and we will come back to them. But otherwise, it's going to be one of these that we're still here at 10 o'clock. And no. Yeah, it's really good that people are so engaged with this. And I think it's really important. So remember, guys, these lives are completely at the generosity of these people's time, which is amazing. We've got all of these videos on our YouTube channel. So all you need to do is go over to the YouTube channel, which one of the ambassadors will put on here now. And you can use the little search magnifying glass on the YouTube channel to put in some keywords. And, one of these episodes should hopefully come up. So all of our episodes, the amazing Amanda Thomas put some keywords so that people can find them more easily. And we've been doing these now for about 2.5 years. There's hundreds in there. And the more you go to YouTube, the more our ratings go up, the more people we will reach. So that's a good thing. I'd really like you to put a Facebook review down. So please do us a favor. Hop straight into the review section of this Facebook page, if you're on it, and give us a review. Oh, by the way, I really need to have to say, I wanted to mention him. He said hello earlier. Eric, nice to see you.
Wonderful.
And yeah, so we're going to be back with Cameron tomorrow and then Thursday. We've also got an event section on the Facebook page where you can look at who's coming up. I can't tell you how much time it takes me, Esme, Amy, and Nicola. We have to contact these dudes, arrange the times. There's paperwork that has to exchange so that they're happy with what we're doing, we're happy with what they're doing. So please do attend, tell people about them. And that's it. Shut up, Hannah. Until tomorrow.
Let me go.
Let's go. See you tomorrow, guys.